I was just wondering about that.
You're supposed to wear all blue.
But they're strong though, so. Got 2 little Texans now.
Oh,
Yeah. It's funny. It's born. You get this immunization. Congratulations on the next one.
I'm shopping for a new
Oh,
car.
sorry. Put 2 and 2 together. I was just like, oh.
Well, but if you need to talk to anyone,
So they send that all out.
you know, that's one of the great things.
A lot of stuff out there that's innovative, personal touch. From the governor. It's not letter that is,
Yeah, she's
you know,
in Bill.
it's tight, but it's personal.
I think on the 16th of April, she's in town.
Everyone will try it out, but for me, it's very comfortable, and the seat is adjustable.
Yeah.
Yeah, I've thought about that. I know.
And if you want it to be sexy, it's the same thing.
Hello, sir.
Oh, really?
It's interesting, in the 9 years that I was there, they opened up for drilling for oil. So all these, you drive these farmers,
You can get it,
all
the Ford is a very high end, it's adjustable.
3 months.
Ford today was
Massive.
You're color coordinated.
There you go.
There you go.
I thought you were the best.
Literally miles and miles.
You and
Hey, that's very proud of you guys.
You know.
You ready? You went and bought the real stuff? No,
No,
Yeah, for Alzheimer's. I don't know how long it's going to stay.
You all moved in?
No, I'm almost, I got lots of packing. I had to move twice. You're right.
Right.
I sold my current condo, but I can't move into the new one until September. They're still building it, so I'm moving into the apartment for 3 months. So I'm packing stuff that I need for 3 months, and I'm packing stuff for the movie stuff.
Lovely.
There's no hotel.
The logistics.
There's no nothing. Permanent tour guide. There's a handful of these guys. And then the next one's one all Island Harbor, which I guess next.
Yeah.
Actually, I presented that again.
Okay, there you go.
I always found myself. Yeah. Yeah, it's small, culture. Yeah.
So I told the woman,
One time I
secretary, now his name Francis, in charge of him, and took over from Trixie to switch you to.
It is true.
Polishing it, there's always polishing, make it better. You still have 2 weeks.
It's something like that, but you got to put it on fire.
Oh, yeah, it was some problem. I mean, in some ways it's good. I waste time working on it. I just keep doing more and more when I don't probably.
But Cleveland, and it's not like the top 10, but you get there and it's
Crazy and everything hard.
We'll do work, so we
Big symptoms.
Okay, sir.
yeah,
Absolutely.
What's that?
Put it on the list.
Here?
I don't know what the
But you're right, I wouldn't miss this for the world.
Take up the field, around stadium. If I always get something going on with
Oh my God. Huge.
He's like, oh, okay.
Morning.
Had a picture of me, then you look at us out the window and disgusted by our behavior. He's inside looking through the glasses. Good, how you doing? Will those guys ever grow up, right?
He set a good example.
Yeah, I agree. Well, he wasn't there. He would have been a part of it.
Yeah, he had gone home already.
Yeah, probably a good thing.
I'm doing great. How about yourself? It shouldn't be. My baby's He's almost 9 and funny.
And then me, yeah.
You have to talk.
You got all the day.
Lori Joe is supposed to be managing. I've only tried on one person. I think others.
If I can help in any way, let me know.
I don't know if I've got a dose.
I had a hard hell of a time just getting fast.
I had a guy yesterday who was started on grass jack, and then his insurance won't pay for it.
Yeah, that's what I've had.
And the curious thing is, he's the only patient, he's not my patient, but I
That's
just
the
covered
kind of way.
with somebody. He's truly just monosensitized to grass. Hey, how are you doing? He does that. Good choice.
What do they think?
Insurance will pay, and the fridge was put up the door. So he came back in.
If I can help
So
any
I
way.
just went back up and said, and I don't know if you saw the data that I showed from Steve Durham's study that reinforces my bias. Plus you can't cover all the other things.
You know, they say, well, the losing your round is better. Then it loses the whole purpose of the convenience of it. If you're going to use your round, you might as well be on shots.
Well, I think the European, I assume that compliance would be good.
Yeah, it's worse.
It's worse. People are lazy. So
Yeah.
like 20%.
Yeah, I got it. I had one guy do it too. Sure, he got himself. Of course, got nothing. Heroin. Came back, they sprayed him. But I've got monosensitized.
We have Gigi today.
And I put
Just a titch, so we can all squeeze in.
Well, yeah.
Yeah, right. Oh, and I have to. Oh, absolutely.
Hey Frank, you know, you pass a handout.
Yeah.
Yeah.
It's a fun age.
Got a job with the drug company, yeah.
No, you got any leads?
No, I remember you asking guys about it. But
They're just about to be 11 and 14. Yeah. How old are they? Yeah. They might have them locked onto that.
Well, I don't think mine is either.
The word of the day is Denver.
Well, I don't want to work. I want to consult.
Well, let's go ahead and get started. Drew was here this morning talking about an update on Biologics. Just one thing I didn't mention to you guys, I don't know if any of you had any kind of problems in Los Angeles. I was going home from the dinner that we had on Sunday, and I ran into a crowd of ruffians on the street. And
But you became one of them.
well,
You joined.
I had to fall in with you have to, fortunately, I got a picture of the group on my way home. Any of you run into any of these characters? They're really
Pretty
nasty
frightening.
bunch. Enough said.
Where's the
Anyways,
cigar?
Next year's meeting, just watch out for this group. Apparently they move around the country attacking allergists.
What happened to the cigar?
Huh?
There's no cigar in
Yeah, I don't know. It's Pandora, I think.
Must have hit
swallowed
it,
the
yeah.
cigar. All right. Drew is the speaker today. That's a switch from the original schedule when Lisa Winteroth was the speaker. And I did have to make just one other switch yesterday. If you're looking at the schedule, the guy who's going to be the substitute dermatologist, I don't know how to pronounce his name. Do you know how to pronounce his name, Dan? D-O-O-S? Anyone?
Who's?
Just the way it sounds.
Who's there?
Anyway, he and Gary have switched, so those talks are coming up in April because he had a clinical conflict, so just looking at that schedule. So Drew, the word of the day is Denver.
Intimidating crowd there. Before I begin,
Well, you know, one other thing before I forget, if anybody didn't reimburse me for coming to that Sunday, if you can hear me, it'd be nice to reimburse me.
before I begin, I do this every year, I want to make sure people know that all of these talks are downloaded on YouTube, and you can go to the Allergy and Immunology fellowship training site, and you can access all of the old talks, which I use periodically here and there, mainly when preparing some of my talks, so it's a great resource. All right, so I don't have any conflicts of interest. I am the PI in a compassionate use Omalizumab study for hypereosinophilic syndrome, and believe me, I get no kickback from that. So, and if anyone wants that study, they can have it. It's going to go over the biologic agents, the Anti-IgE, and we've been using that for years and years. But there's some new papers that were reviewed at the meeting that I wanted to go over. I thought were really interesting. The Anti-IL-5, which we have as of 3 or 4 months ago, and we've started using in our clinic. It's been great, and then some coming down the pike, hopefully soon. This was all the rage at the national meeting. This endotyping patients, as we all know, asthma is like arthritis. It's like anemia. There's a lot of different pathways that can lead to a similar clinical outcome, and knowing these individual pathways, such as AERD and allergic asthma, can help kind of classify which of the severe asthma patients will qualify for some of these other drugs, and there's a lot on the horizon. For instance, if I gave this talk last week, this drug, another anti-IL-5, Omalizumab, would not have been approved, and it was approved in the last week. So I'll go over some of the data for that as well. So this is very simplistic, obviously, but this is kind of the way I think about asthma and the treatments that can be helpful for it. So simplistically, there's some airway insult, either by allergens, pollutants, infections that causes these innate immune cytokines to release things like IL-25, IL-33, TSLP, which I'm going to talk about later because there may be some agents coming down the pipe regarding anti-TSLP. And these uncommitted T cells go down the Th2 pathway and release IL-4, IL-5, IL-13. Eosinophils are produced. And then IgE, which is not an interleukin, but altering that production can be helpful. So this is where most of the asthma research and development is focused at this point. Unfortunately for neutrophilic asthma, they've looked at a lot of different mediators in this, and it's not nearly as promising. So the anti-neutrophil, that asthma neutrophilic endotype, we're a ways away from having other agents there, it sounds like. So as you know, most of the patients we see in clinic, we can get by with our normal agents, the ICS, LAVAs, leukotriene blockers, anticholinergics. But there's that severe subset that we all see that just doesn't respond to these, has frequent exacerbations, the quality of life decrease, and this is where this comes in handy, the customization of the Th2 high versus the Th2 low endotype. And again, they talked about this a lot at the meeting. And that helps identify which are more likely to respond to these type treatments. Again, IgE is not an interleukin, but it binds to mast cells that causes activation and release of Th2 mediators. So it's involved in this pathway, and altering IgE has been shown to be effective. So I was going to start with a new toy we have to play with, which is the anti-IL-5 agents that got approved in December, and I've gotten 2 patients on it. Matt, how many do you have? 4 patients. So we've managed to get some people approved for this. In the room, how many people have gotten this drug approved for their patients? So, yeah, it can be tricky. I've had to talk to the companies for both of them, but I saw one of them in follow-up yesterday, and he was doing really well. Steroid dependent, we were finally able to taper some of his steroids. So IL-5 produced by Th2 cells, involved in terminal differentiation and maturation of eosinophils. It mobilizes eosinophils into the circulation, and all these studies are going to show it's incredible at kind of melting these eosinophils and decreasing their total counts, especially in the peripheral blood. So it leads to increased survival and cytotoxicity. And again, Mepolizumab just got approved recently. Now, what I found interesting in this is, this drug's been studied a long time. The first study was published regarding this. The first major study was in 2000, so it's been around 16 years and we've been studying it, but the early days kind of got off to a slow start. I'm going to review these 3 early studies, basically proof of concept. So the aim of this first one, and again, I'm going to try and show when they're published, and that's on the left side of the page here. First one was mild allergic asthmatics with a single dose, so just 1 dose of Mepolizumab in patients with a baseline eosinophil level of around 300. They did is give them this drug and performed inhaled allergen challenges several days afterwards, and this is the first study showing that this drug significantly reduces the eosinophil level in the periphery, in just 1. It also decreases sputum eosinophils as well. But unfortunately, it was not good at decreasing the histamine PC20, so it didn't change the airway hyperresponsiveness, so at least just 1 dose in mild asthmatics, and their findings was they questioned the role of the eosinophil in mediating the late allergic response. I thought that was a little broad brush to paint with that, but this is the first study basically showing that eosinophils do respond to this drug, but the clinical outcomes weren't there. The second one was in 2003, and again, looked at mild asthmatics, and it looked at not only the peripheral eosinophils, but also in the tissues. And this gave 3 IV doses of Mepolizumab, high dose, 750 milligrams. That's a good dose. That's what our hypereosinophilic patients start out at. And the blood EOs were around 300 in this. Down here, as previously, it showed that there was 100% reduction in the blood eosinophils, but it also showed in the airway and biopsies and also in the bone marrow that this decreases eosinophils as well. There's no change in the histamine PC20 or the FEV1, so nothing as far as clinical. And again, they said we don't know whether eosinophils are related to asthma as well, but again, it's these mild asthmatics and just a few doses of Mepolizumab. In 2003, a similar study came out looking at the patients that we now think of as being appropriate for this agent, the severe persistent asthma. And they looked, and the FEV1 significantly diminished, 50-60%, and the blood eosinophils around 200, 300 in the treatment groups, and much higher, interestingly, in the placebo group. And they basically showed that again, eosinophils declined, but there was no significant change in the FEV1 at 24 hours, and no other change in clinical parameters. They had diaries of symptoms and all that. So again, the study did not show it showed really well that eosinophils declined with these medications, but the clinical outcomes just weren't there. Again, short dosing periods, mild asthmatics, the peripheral tissue eosinophil improved, but the clinical outcome was just not there. So fast forward to 2009, and this is a person a lot of us know in this room, Ayars, who's up at the Firestone Institute in Ontario. The reason I love this study, because we actually piggybacked one of my projects as a fellow looking at airway remodeling in the sputum of these patients. And then another one that came out in the same year that really kick-started, I think, the push to get this medication approved. So Parham's study was his severe asthma patient population. He's got quite a cohort up there of these severe asthmatics that required oral corticosteroids with severe persistent asthma, and as you can see, FEV1 was severely diminished. And interesting, in the placebo group, only 4%, and treatment group, 16% eosinophils. And the prednisone, they randomized, so they would have, on average, 10 milligrams of prednisone required to control their asthma. What they did is slowly taper the prednisone over a pre-specified algorithm. And if they had an exacerbation, they weren't allowed to taper. So basically, the tapering effect was showing that they had a lack of exacerbations. And it did so fairly nicely. The mepolizumab got down to 3.9 from 10 milligrams, an 83% reduction. The placebo got down 6.4, which is about a 50% reduction. There was not a statistical difference, but it did show that they were able to decrease that prednisone more. And this is more interesting data. There were 12 total exacerbations in all of these 20 patients, and 10 were in the placebo. And 10 of the 11, and if any of you know Parham, he kind of classifies these exacerbations. He's either eosinophilic or neutrophilic, and if they're eosinophilic, he gives them more prednisone. Neutrophilic, he more hits them with antibiotics. And of these 10 in the placebo group, 7 had eosinophilia, so a good majority. And the 2 that had exacerbations with mepolizumab, neither of them had this eosinophilia. So this was kind of a marker that the mepo was working to decline these eosinophilic-driven exacerbations. Again, it's pretty incredible how this drops their EOs in this test. And as you can see in the placebo group, the EOs went up because they were tapering their oral steroids. It was a fairly small study, 20 patients, but they showed by selecting the appropriate patients for this can be a nice drug to use, and this kind of kick-started things. In the same year, 2009, a bigger study of 61 subjects in severe asthma with sputum EOs greater than 3%, which is what Parham used, that had at least 2 exacerbations and required oral steroid treatment within the previous 12 months. Mepolizumab group was 29, placebo was 32, and they were on this for a year, so a little longer than the previous study, and the primary outcome was severe exacerbations. They didn't try and taper their oral steroids if they indeed were on oral steroids. So these were not as severe asthmatics as the previous. About half were on oral steroids, and their peripheral EOs were around 300. Again, this showed this is the first major study, I should say, that showed a significant decline in exacerbations in these patients treated for a year. It was almost half. 2 exacerbations in the treatment group and 3.4 in the mepolizumab treated group. Also, it improved quality of life, which is the first study showing that as well. So this was a major study, and I think kind of kick-started this. Significantly lowered eosinophils. I should stop saying that because that happens in every study. There are no differences in FEV1. And again, this showed that mepolizumab reduces exacerbations and can improve asthma quality of life questionnaire in these refractory patients with eosinophilic asthma.
How often was the drug given? Was it IV?
It's IV and it's every 4 weeks. It's always every 4 weeks, whether that's subcutaneous or IV. There's only one study which I'm going to talk about that's a major study, which is part of the reason why we have it available sub-Q now, and that's how we give it. So we made progress here, larger studies, and there's directed therapy. Again, picking the right patient population with a decrease in exacerbations, and that's going to be a theme from here on out. And this is the first one showing an improvement in the quality of life. So now we get to the bigger studies, and this one came out in 2012 in the Lancet. And it was 2 or more exacerbations, again, in these severe asthmatic patients requiring oral corticosteroid therapy. And again, this one uses sputum eosinophilia, which any of you who use or look at sputum eosinophilia know it can be fairly tricky to get a good sample. At 81 sites, they randomized to placebo, 75 milligrams, 250 milligrams, or 750 milligrams, which is kind of the high dose. And they gave 13 infusions. Again, it's every 4 weeks. And they looked at exacerbations, what they defined as OCS therapy, inpatient admissions, or acute care visits. This is a much larger study than the previous. 621 patients. FEV1 about 60% in these patients, and the peripheral EOs in the 200s. They showed in all groups, again, that this decreased exacerbations. 750 milligrams, that's a 75 milligrams, and 250. So there really wasn't a dose-dependent difference between these groups. Again, serum eosinophils are declined. There was no difference in sputum eosinophils, interestingly. No difference in FEV1. And in this one, the quality of life did not improve either. So significantly reduces the number of asthma exacerbations, which is really important, but the quality of life and FEV1 did not significantly decline in this study. And this is one of the major kind of landmark studies with Mepolizumab. Came out in 2014 by Ortega. Again, a very large study looking at severe eosinophilic asthma. And in this one, instead of using sputum eosinophils, they used peripheral eosinophils, which is nice because a lot of people don't have access to sputum eosinophils, or at least done well. And again, Q4 weeks, they treated for 32 weeks with SIBO. They used 75 milligrams IV, which is a tenth of the 750 milligram dose, and then they also randomized the sub-Q, so 100 milligrams sub-Q. Again, primary outcome was exacerbations. Secondary, FEV1, quality of life. Again, FEV1 is similar to these previous studies, around 60. About a quarter of these patients were on oral corticosteroids. Peripheral eosinophils were not robust. The patients I've got approved for Mepolizumab are 600, 700, 800 at baseline, and significantly worse during exacerbations. So, again, showed a significant decline both in the IV and subcutaneous, which is fairly significant. It was nice showing that the sub-Q, which is much easier to administer, was as effective as the IV. They actually showed in this study that it improved FEV1 as well. It also improved quality of life, which is great, and that's one of the major things that patients care about. So again, landmark study really helped get this approved. Significantly reduced asthma exacerbations and other control markers in this. So.
Drew, do you know in that study, did they try to stratify it all based on high versus, relatively high versus relatively low eosinophils?
That study, I don't think they analyzed. I'll look at that.
I mean, that's 150 is so low, which anybody will get there.
No, it is amazing. I was surprised to see that how impressive the outcomes were, even in that low.
It would suggest that maybe you just need to pick any severe asthmatic rather than those early studies, which were mild asthmatic. Eosinophilia. I mean, maybe the eosinophil count doesn't even matter.
Interesting, looks like periostin and other markers of that as well.
How come do you think that this worked at a lower dose and the other studies at higher doses? I mean, what's your gut feel? Just a different patient population?
I don't know, because they're fairly similar patient populations as far as FEV1. It's a good question, and I don't have a good answer for why this data was so much more impressive, although, both showed a significant decrease in exacerbations, but why this study, which had fairly similar numbers, to improve quality of life and FEV1, it's hard to tell, because the patient population was fairly similar.
The DREAM study suggests the dose doesn't really matter.
Yeah.
You don't need much to clear eosinophils.
And they did show that here. But, there's no significant difference between all of those. And that's why we have the indication of 100 milligrams sub-Q now instead of the much higher doses.
So was it able to block all the exacerbations? I mean, what, the viral ones as well as...
They didn't look at what they thought the exacerbation was from. They didn't look at sputum versus eosinophil versus neutrophilia. I have a study later with Xolair that looks into that a little bit. But yeah, no, they didn't go into that.
Drew, did anyone look at the aspirin-induced respiratory?
They didn't comment on that, whether they had aspirin
Whether
sensitivity.
they excluded or they probably didn't exclude that?
I'm sure some snuck through, Yeah, I don't know. They didn't comment on whether they were excluding AERD patients or not. Nick?
What's the half-life of the drug? And you said every 4 weeks is the usual administration dose. Mm-hmm. So how long does it last? And can they measure and monitor the level?
I don't know the half-life, but I can say, just having experience with this AGS protocol, that the EOs don't really wax and wane over the course of the dose, meaning it's able to diminish eosinophils over the course of a month, because we have to monitor it every 4 weeks on this study, and there's not a significant decline month by month. So it's effective for at least a month, and we know that, at least looking at peripheral EOs.
In the first primate studies they did with it, the single dose knocked it out in chimps for 6 months.
In the first data I showed, they looked at 3 months later, and the peripheral EOs were still declined. So it's impressive that decreasing these EOs.
Drew, one question Tillis asked was, if you have people on steroids, it's obviously an anti-eosinophilic in itself.
Mm-hmm.
And the question came up, how long do you have to be, if you want to stop somebody's steroids to get them approved for this drug, and you have to get them back up to at least 150 EOs, how long does it take for your EO count to bounce up when you stop prednisone.
I don't have data for this, but I actually did it with these 2 patients that I got approved, and I had them back a month later, and their EOs had shot up. So it's not long before those EOs would be bad. I don't have a specific number, but to get this drug approved, that's what I had to do. I had to take them off their oral corticosteroids, or at least wean down and monitor their EOs count. And it shot up fairly quickly.
Yeah, I mean, steroids only work, they just cause eosinophil apoptosis, which, as soon as you withdraw, the eosinophils will.
Yeah, I thought it would come back. I actually sent that question to Jerry Gleich. Gleich's an eosinophil world expert. And he wrote back to me and said he didn't know. He couldn't believe that.
And actually, it can go. If you think about it, it's
come back quickly.
It'd be quicker.
They do because they're being made.
You get high levels, even better.
Steroids don't really
Just
suppress
open.
production. They just
They mostly marginate EOs.
No, but it will rebound after that. So if you think about Addison crisis, one of the signs is elevated eosinophil count. So if they were on eosinophil or prednisone for quite a while, once you stop it, then you get high levels.
So that's a good way to get them
That's
on
perfect.
That is a good way. All right, again.
Do you know anything about, since, the drug's been around for so long, even though it's just been approved, what that means for generics and whether, how long it will be patented?
I don't know the patent.
15 years.
It's a
You
good
get
question.
17 years.
From the date of approval?
I assume approval date, but I don't know.
That's not fair. Usually from when they first started.
That question will probably come up about Omalizumab, too. I don't know. We've had that
15
for,
years,
what,
isn't it?
11, 12 years?
It's been out a lot longer. I mean, the research and development is way longer.
Did anyone
can
check
really
that
answer.
IL-5 levels? Did you try to call
Jerry,
it?
when you go off patent?
They looked at IL-5 in the hypereosinophilic studies, and those are very variable throughout the day, so it's not supposed to be a good marker.
So again, Omalizumab was approved last week, less than a week ago. So looking at the data for this is one of the major trials here, asthma not controlled on medium high dose ICS, and they chose a much higher EOS level for their cutoff. They also used IV doses, 3 milligrams per kilogram, so weight-based. Treated every 4 weeks. Again, all of these are 4 weeks for 52 weeks. Patient population, again, similar. FEV1 around 60%. Their EOS levels were much higher in this study. And about 10%, around that area of percent on oral corticosteroids. And they used an interesting outcome. I haven't seen this used a lot. Rate ratio, a relative difference measure to compare incidence rates of events occurring at any point in time. So again, kind of the same outcome. They also looked at FEV1 and quality of life. And again, there was a significant reduction in the frequency of asthma exacerbations in these patients. They also looked at FEV1 improvements over the 4 weeks, and they continued. Again, at 4 weeks, they had an improvement in their FEV1, and that was persistent throughout the study. And again, this also showed an improvement of quality of life in these patients. Now, unfortunately, 2 of these patients had anaphylactic episodes during their IV infusion, so that will come up, obviously. And these patients were withdrawn. It was relatively mild anaphylaxis, and they treated in clinic. They went home, but it was documented as anaphylaxis with this drug.
And did those occur after one with the first infusion? Is that correct?
I didn't see what infusion it was, but yes, it was the first infusion for both of them, I believe, which is interesting.
I don't think there have been any cases with MEPO, right?
I looked and I didn't see any reported cases.
I think one is IgG1 and the other is IgG4. I forget, right? They're not identical molecules.
No, yeah. Different.
Just curious.
Yeah, but I'm sure they weren't thrilled about that. So, on to the next, again.
Drew, on that, when they announced the approval, they also said there was a cancer warning. Did you see anything about that?
I didn't see anything on cancer because they didn't discuss it in the study. I didn't read the press release, but wasn't it similar with Xolair as well when that was released?
Yeah. That other one. Remember Xolair Plus? Remember the one? You know what I'm talking about?
What?
Remember when Xolair, remember there was that second drug that was like this next generation Xolair, and they're trying to do it with the food studies, but then they had all those chimpanzees die. I don't know. Maybe I'm making it up.
Those monkeys died from ITP. They
Okay,
had,
right.
had ITP.
All right.
Not from cancer.
Okay.
They saw that with Xolair too. Like they saw the drop in platelets with Xolair, like super high dose.
Hey, Drew, since you're moving on, can you summarize like what the appropriate patient to give this drug to?
That's a great question.
Right, because you got to think about, because you get that question about, well, what did they set a specific criteria by the FDA?
No, they haven't set a criteria, and that's the interesting thing. I was talking to David Gossage about this yesterday. He was involved in drug development, and he said basically if their EO is over 150, theoretically you could apply for this medication. Obviously, it has to be severe asthma. They have to be high-dose ICS, LABA. It helps if they're on prednisone, which is the patients I've gotten approved for it. But there's no exact cutoff for this medication. 150, you could theoretically apply.
Oh, is that right? Yeah, I guess I thought I haven't looked. You know, I'm on SU service, but I haven't looked at that. But I thought they were going to set a specific criteria.
I've heard 300, 350, but
150.
150 is in the package. Is in
150, you can theoretically go down to 150 because of that study.
Mepolizumab or
Mepolizumab
is 150 within 3 months. The last
which is a ton of our asthmatics.
Yeah.
So it would be interesting. And then which agent do we use? That's going to be a discussion. Xolair.
Well, it looks like this newer one's going to have its problem. It's IV, the episodes of anaphylaxis.
Oh yeah, I'm talking Xolair versus mepolizumab. Yeah, the reslizumab. We'll see how that pans out.
They got a lot of problems right out of the gate.
Right. You know, did they not study SubQ?
No, at least that I saw.
It seems like that's so late.
And it was just that one study that looked at it SubQ, which is great.
One other comment on mepolizumab. I know there's a study ongoing now where they're giving it in the setting of an acute exacerbation. Just thinking, Teal mentioned he's in the ICU. I'm just thinking about our people who are coming in acutely very ill. So that may be a indication down the road.
That's interesting.
But it does work very quickly. I mean, in our hypereosinophilics and that, they're better within a day. You know, so it's true. To think about
comparing it with steroids, or
maybe
both.
I think it's versus conventional treatment. Yeah, I don't know if they're getting steroids with it or not. Probably.
Maybe three different.
Somebody wrote an editorial about how expensive it was, which I can't remember what it was, but it struck me as very short-sighted, because if you prevent an exacerbation, especially an ER exacerbation, probably costs $20,000 to get out of the ER, a whole lot less than one dose of the med. I mean, it's not expensive like HAE drugs, which are $500,000 ridiculous.
So, moving on.
Prednisone's cheaper, yes.
Moving on. Most people in this room know the early studies with Xolair, but there's one I reviewed a few years ago in a talk, and another one I listened to Bill Bussey talk about at the meeting that I wanted to review. Most of us know this study, which is a randomized trial of Omalizumab for asthma and interstitial, so the interstitial asthma studies that evaluated the effects of exposure and sensitization to allergens and severity of asthma. So it took intercity kids anywhere from IgG to 30 to 1300 who were sensitized to one perennial aeroallergen and assessed the effectiveness over 60 weeks. So a long study. There were 419 enrollees. And the primary outcome was the number of days of symptoms within the previous 2 weeks. They also looked at exacerbations, spirometry, asthma control tests, and as you can see, they were around 10 years of age on average. FEV1 in the 90s, but these with recurrent exacerbations and sensitivity to aeroallergens. So I love these curves, and I thought this was interesting. I think piggyback to his next study. But the days with asthma symptoms significantly declined in this group, and mainly during the spring and the fall months, and especially the fall months when kids are going back to school, exposed to viruses and things of that nature. So symptoms and exacerbations improved, and that's fairly significant, especially over those time periods. There's not a real difference here in the summer months when they're at home, not exposed to other viruses, or in the spring when the aeroallergens are out. So their conclusion was, when added to guideline-based therapy, Omalizumab further improved asthma control and nearly eliminated these seasonal peaks and exacerbations. Thinking back on our patients, a lot of the ones, especially the kids that I see, that's when they're coming in. Which kind of led to this study that he reviewed this year at the meeting. It was published in 2015, looking at short-term targeted treatments, trying to prevent the seasonal exacerbations, and mainly during the fall when they're going back to school. And this is a fairly complex study, looking at a lot of different arms, the severity of asthma treatment level 5, also comparing Omalizumab to basically increasing their ICS dose during the fall to a maximum of 1,000 micrograms, equivalent of fluticasone twice a day. So again, they compare Omalizumab with placebo, Omalizumab with ICS, and then this more severe patient subset. So they took kids aged 6 to 17, and 4 to 6 weeks prior to returning to school, they started them on Xolair, and they used our standard dosing regimen. There's a 4 to 9 month run-in period, which was important, and there was a 4-month intervention phase, and they looked at fall exacerbations, and this was done in 2012 and 2013, and a fairly big study. 513 were enrolled. So the fall exacerbation rates decreased significantly, both overall in the steps 2 to 5, and then also much more so in this severe step 5 asthma group. There's no significant difference between Omalizumab and ICS boost, but this was done in the less severe asthmatics, the step 2 to 4, because the step 5 obviously were on maximal therapy at that point. But in a pre-specified subgroup analysis, they looked at the patients who in that run-in period, the 9-month period or 4-month period, depending on the patient, and saw whether they had an exacerbation over that time frame. In other words, your frequent exacerbation patients. And they showed that was fairly robust. In the placebo, 36% had an exacerbation versus only 6 in the Xolair treated group. So, this is more of a direct, and they were talking about costs associated with year-round administration of this medication, and saying that this may be more of a targeted approach to prevent these exacerbations during those peak seasons. They didn't look at it other than that first study I talked about prior to the pollen season, and those were sensitized to the seasonal allergens, which I think will be another interesting study. So I'm going to briefly go over one of these studies, mainly because they did an analysis of this data, and the one I'm going to cover after this, and looking at specific subgroups of asthmatics. So this paper basically told us what we already know. It's a large study looking at Omalizumab in age 12 to 75 in a good size, 850. They were inadequately controlled despite ICS and LABA in the 48 weeks of treatment. Primary outcomes were exacerbations and albuterol use, symptom scores, quality of life, secondary. And they showed that exacerbations were significantly reduced in this patient population. Again, we knew that. Quality of life was also improved on these Omalizumab patients, and reduced albuterol usage as well. So, again, we knew a lot of this data, and this is basically just to back a lot of it up, but they did a subgroup analysis. This original one was 2011, the next one was in 2013, and basically stratified these patients in the Omalizumab group, looking at exhaled nitric oxide, FeNO, blood eosinophils, and they also looked at serum periostin in this group as well. And they were divided into low and high biomarker groups. And they looked at protocol-defined exacerbations, both in the high and low subgroups of these patients, and it was fairly significant. 48 weeks of reductions in protocol-defined exacerbations were significantly more impressive. So there was a 53% decrease in the patients with that FeNO greater than 24, and it was much less impressive for patients that had the lower FeNO. Similar, eosinophils in the high eosinophil group, there was a 32% decrease, and in the low there was a 9% decrease. So, stratifying these patients is really interesting because they really do respond differently to Omalizumab treatment. Then periostin is another thing. I don't think this is available as a commercial assay yet, but it may be in the future, and it's another nice biomarker. And again, in the high group, there was a 30% decrease in exacerbations versus a low, just 3%. So it would be interesting, and I wish we had an FeNO available in our clinic, but I'm going to start looking at eosinophils now in the patients I'm looking to put on Xolair to see if I can get any better clues or any further information on whether I think they're going to respond well to this drug or not. So I thought this was a really interesting study.
I mean, since it's an anti-IgE molecule, did they stratify the data just based on the IgE level?
No, they didn't. I think they didn't because we dose towards the high versus low, so it'd be a difficult thing to look at. But no, yeah, it'd be interesting as well. But no, they didn't look at those. It was just those 3 biomarkers.
Well, and they were probably dosed on their level anyway.
Yeah, no, that's why they didn't do it. So there are higher levels of Xolair were used.
You didn't mention it, but in the intercity asthma, what they think is going on with Xolair, that it has nothing to do with IgE, but it rather is affecting the interferon response, and that's what they believe is the mechanism of efficacy.
How does it affect the interferon?
Yeah, basically it increases basically kids who are having exacerbations have a deficient interferon response, and that's what is in part leading to the exacerbation of this reconstitutes it. Now, how that happens is unknown.
No.
But because there's no evidence that decreasing IgE and all this is what's actually the rationale behind why Xolair works. So that's sort of their hypothesis anyway behind the efficacy of it.
All right, moving on. So again, for Xolair, looking at some of those biomarkers, I'm going to start paying more attention to, and patients that don't like taking it all year round, at least trying to focus it to a certain time of the year. And it'd be interesting to see whether there's a similar study coming out regarding the patients that are sensitized to seasonal aeroallergens as well.
Drew, have you found any information about when Xolair might get approved for the younger groups? Like, there's so many great studies for the younger ones, like less than 12s.
Little Birdie told me pretty quick, but
I heard the meeting's going to be real soon.
That'd be great.
It should be coming soon. Moving on, these anti-IL-4, anti-IL-13 agents that aren't available yet, but we're hoping to have access to them here in the coming years. So this is a nice review from the Lancet that I really like looking at. IL-4, IL-13, and IL-4 can interact with both the IL-4 and IL-13 receptor and has an important role on that Th2 differentiation from the naive T cells. It promotes isotype class switching towards the IgE synthesis of these IgE producing plasma cells and upregulates the high affinity IgE receptor. IL-13 just acts with the IL-13 receptor, but has kind of similar effects, other than the fact that it doesn't promote that Th0 to Th2 differentiation. It's secreted by mast cells, basophils, eosinophils, increase the goblet cell differentiation, activation of fibroblasts, increase of bronchial hyperresponsiveness, and both IL-4 and IL-13 upregulate vascular cell adhesion molecules on endothelial cells. So basically, they bring in other molecules as well. Again, IL-4 and IL-13 are similar, but the IL-4 just causes an increase in these Th0 to Th2 cell. So, lebrikizumab, which is an anti-IL-13 agent, has been looked at for a while. The first major study came out in 2011. It looked at 219 patients with uncontrolled asthma despite inhaled corticosteroid therapy, and they looked at a predefined subgroup with periostin levels and looked at both high and low periostin. They really didn't specify other than it was above or below the median in the study. And the primary outcome was, I thought it was interesting what they were looking into with the change in pre-bronchodilator FEV1 from baseline to 12 to 24 weeks. And they also looked at quality of life and exacerbations. Patients' FEV1 was around 65% in both. Most of them had a positive skin prick test. FeNO was around 30, so greater than that 25 cutoff at that previous study. And primary outcome, FEV1, was significantly higher in this group. There's a significant difference between the high periostin and low periostin. It was 8.2% increase in the lebrikizumab group, and only a 1.6 increase in the, which was not significant, in the low periostin. So, kind of classifying high versus low periostin will be important if we ever have access to this drug, and hopefully that will be soon. There was no difference in the quality of life or exacerbation in this study, and basically they said that this agent is associated with improved lung function. Patients with high serum levels of periostin had greater improvements, and that was fairly significant, but didn't change exacerbations or asthma symptoms. Now, in 2014, a much larger study came out. It's actually a combination of two studies with uncontrolled asthma, despite high-dose ICS and a second controller, and they randomized into low, medium, and high-dose lebrikizumab, and the goal was to enroll 1,400 patients. So this is a major trial here initially. Primary endpoint was exacerbations in this study, not FEV1. And again, they stratified them for periostin levels, and they used 50 in this group. Again, FEV1 is similar to these other studies, around 60%. Their EOs around 300. FeNO, kind of around that 25 cutoff. And again, this was supposed to be a huge study. Unfortunately, it was a host cell impurity. I don't know exactly what that is. Basically, the drug was unusable for part of these patients. So they had to decrease the size of the study and also decrease the length of the study as well, unfortunately. So they enrolled 463 patients and treated them for 24 weeks. And lebrikizumab was associated with reduced exacerbations, and this was in all groups, not low, medium, and high. So there's no dose response with this. And here's looking at the high periostin versus the low, and you can see this is the placebo, and these are the other doses, and there's not a major difference in that low periostin subgroup, but it's fairly significant in all of the other treatment groups, basically. So choosing these patients with ordering a periostin level and choosing these patients accordingly is, is something that I think we'll be doing if and when this drug is approved for us. Also looked at lung function, which improved significantly in the high periostin group and not so much in the low. Symptoms did not change significantly in this group. And basically they showed that this improved the rate of asthma exacerbations and lung function in these patients. But again, symptoms were not changed.
That's really weird that they basically decreased their sample size to a third. Did they mention, their power calculation must have been way off.
Oh yeah, no, and you can tell they were upset about that.
They got the results they wanted anyway.
We were one of the study sites here, and in the middle of the study, they pulled the study because they had something toxic or something unexpected in the product.
Normally,
and they significantly decreased the numbers.
And it didn't seem to affect their outcome.
Yeah, no, they were looking at exacerbations, and they hit it, especially in that.
On the left, those bar graphs.
So this is it. Yeah. So this is interesting. This is the lebrikizumab at the 37.5. Yeah. So this is the different doses. This is 37.5. This is 125, and this is the 215.
Looks like the highest dose.
Yeah, I know. That was the interesting thing of this. So it's really not a dose-dependent issue. So moving on to another agent that we may have coming down the pike, which is Dupilumab. Dupilumab. It's a interleukin-4 receptor blocker, basically. So it binds to the alpha subunit and blocks the effects of both IL-4 and IL-13. So it blocks all these different agents as opposed to just the IL-13 that blocks through the IL-13 receptor. In 2013, this study came out. Inclusion criteria, so moderate to severe asthmatics, blood EOs greater than 300, sputum EOs greater than 3%. You could either one or the other in that study. And it was the study drug at 300 milligrams, which is used subcutaneously on a weekly basis. Patients, so basically this is like the Paramount study where they put them on the drug and tried to taper their dose of LABA and inhaled corticosteroids over a pre-specified tapering protocol. And they received the drug for 12 weeks or until there was an asthma exacerbation. And again, the primary endpoint was an occurrence of an exacerbation. FEV1 was a little higher in this study, around 70%. Their EOs were around 400, 500. FeNO, 35 versus 37, and their IgE level was fairly significantly elevated as well. So they took 104 patients and showed that this significantly decreased the exacerbations. As you can see, here is the placebo group, and here's the Dupilumab group. And there were only 3 patients out of 52 in the Dupilumab group, even with tapering a lot of their medications, that had an exacerbation versus 23, or 44% versus 6%. So there's an 87% reduction over the course of this trial. And it significantly decreased the time to exacerbation compared with the placebo group. So it was also associated with a significant increase in FEV1 from baseline. And the quality of life also improved in the study, even when they were tapering their medication, so I thought that was fairly impressive. So Dupilumab, as compared to placebo, was associated with fewer exacerbations when LABAs and ICS were withdrawn. Obviously, future studies need to be done, but this looks like an exciting new therapy that could be coming down the pipe. So I think I have a ton to talk about the anti-TSLP agent, which is the other one that may be available to us in the next 5-10 years. So, this is one of the studies looking at this anti-TSLP directed, again, directly at the TSLP that involved 31 patients, which is interesting. They took mild allergic asthmatics and basically gave them 3 doses of the study drug and then did allergen challenges both before and after. These were conducted on days 42 and 84 and evaluated the effect in reducing FEV1, exhaled nitric oxide, and eosinophils. So, you can see these are basically the challenges before the study, day 42 and 84 after the study, and they looked at the percentage decrease. So, they give them the challenges as initially, over the course of several hours, their FEV1 drops, not surprising, comes back up, and again, this is before study drug in both, so fairly similar. Now, when they did this at day 42, there was a significant worsening or significant improvement in FEV1 initially and a late allergic response associated with these challenges. At day 42, there's 34% smaller decrease or decline in their FEV1 versus the placebo group. And interestingly, at day 84 is even more robust, less than 50% compared at both the early and late responses. They looked at other measures. There was a significant decrease in sputum and blood EOs, and also in exhaled nitric oxide with this drug. Basically, this showed that it reduced the allergic-induced bronchoconstriction both before and after allergen challenge. And they did say whether this is clinically relevant, there need to be other studies, and those are ongoing at that point. So we're still a ways away from these anti-TSLP agents, but they are coming down the pipe. So I shamelessly stole this chart from Dan, so if anything's wrong, it's his fault. Although he presented this last year, and he guessed that Mepolizumab would be approved in 2015, and Reslizumab in 2016, and he was right. Now, the anti-IL-13, which I showed you the data is promising. I will say this. There was a press release last month on the 29th, basically saying that the Levolta 2 did not meet the primary endpoint, which is discouraging, and they're trying to tease out what was different, because basically it was the same patient population, and why the first one, which is the same, and the second one are different. They're looking to see, what could be the variation. So this may delay this from being available soon, but yeah, we'll see. Maybe they may be able to tease out some of those issues. The Dupilumab, the new drug application, hopefully by 2017, approved approval 18, it's hard to say. And then the TSLP, we're a ways away from having these agents available, but the initial data is promising, so hopefully we'll have a few other agents available in our arsenal.
There's one other up there you didn't comment on at all, the other anti-IL-13 drug.
Yeah, I didn't look into that one as much. It looks like it's a little farther away from becoming available, so I did not put that in this evaluation. So again, this asthma endotype, trying to classify, especially if you're looking at these Th2 patient populations. We have a lot of other therapies available, so trying to classify this, things like eosinophils, IgE, perennial sensitivities, and trying to find an appropriate agent. The anti-IL-5 are really promising. It reduces exacerbations, and in a lot of these patients improves quality of life and their FEV1. The anti-IgE, new things and new thoughts coming down the pike again, kind of focus it during these two problem areas. Again, when kids are going back to school, especially in this younger patient population, or when the seasonal allergens are in bloom.
Drew, while you're on anti-IgE for a minute, before I went to the meeting, this is off topic a little bit, I constantly have patients ask me who are on it and doing well for urticaria, can they stop, when can they stop, can you change the dosing interval? And I said to all of them, well, I assume there'll be information on that at the meeting, and I'll come back and I'll tell you what I learned. And I didn't learn anything about that issue at the meeting. And did anybody know either mechanistically why it works for urticaria, assuming receptor downregulation, and anything about what I just said?
Well, you know what? I just had to look. I went to Up to Date recently, and I looked up chronic urticaria because I didn't know the dosing. Because if you actually go to the Xolair website, I couldn't remember if it was 300 or 150.
300.
Well, okay. Well, it's approved for 150 and 300. And what they tell you in the Up to Date is you can start them at 300, and if they're well controlled, you can go down to 150. Like reduce their dose in half and see if their hives are well controlled. And then I can't remember what they say to start weaning off their antihistamines and stuff. So anyway, you can look up to date, and that because I didn't know that either. I literally looked.
I don't know if there's any data. That's just
right. I don't know if there's data or not.
I just try stopping it after like 6 or 9 months, and if it comes back, they go back on it.
It usually comes back.
Nobody's really looked at that.
Yeah, or you tell them to come 2 weeks late.
Yeah, or that's what we often do too, right? They either miss a
Don't put
dose
that
or
in the
whatever.
chart.
You came off.
Yeah.
I usually have them back at 3-month intervals. Their hives are completely controlled, 0 breakthroughs. So
I mean, we have so many patients on it. It's something we can easily assess. We can.
Yeah, I must have 50 people on
But I don't think there weren't any posters that I saw. Or
My concern is if you stop it and it comes back, because it's going to come back almost for sure, then it's going to be harder to get insurance to pay for it a second time. They're going to say, why'd you stop it? You didn't need it anymore? And deny it.
Or they may do what they do currently with IgG, make you show that you still need it at the end of the year, and then you flare up and you get back on it. A lot of the insurances are now requiring us to get a baseline IgG off of therapy. IgG therapy to make you drop, show that their levels go below therapeutic, and then you get to put them back on.
You're talking about for CVID, things like that.
But they're starting to do that now, I think probably for cost reasons, but it may end up being the same thing with this. You show it comes back without it, and maybe they'll reapprove it. It could go both ways.
Yeah, it's the people in our office who get the approvals are going to be pissed off if they have to get reapproval.
I have a view.
Why you stop it?
Yeah, that's true.
again, these anti-IL-4, anti-IL-13 agents will hopefully be available soon. Anti-IL-13 improvements in pulmonary function, reduce exacerbations, especially if you look at the subsets of high periostin. Dupilumab hopefully be available soon, improves pulmonary function and exacerbations, but that's a little farther away from approval. And anti-TSLP, another promising agent, hopefully we'll have available. And again, unfortunately, they looked at multiple different ways to kind of combat look at neutrophilic asthma, and that has not been nearly as promising. There's not a lot that will be available.
There is actually. The anti-IL-17 was approved recently. So
It was improved, wasn't it?
for psoriasis, so if you
What?
for other indications, the anti-IL-17.
Yeah, for the asthma, it just hasn't been. No, and actually, there's initial promising data in the TNF blockers, but they did a second larger study that did not.
But if you have a patient with asthma and psoriasis, maybe you can treat him with anti-IL-17 and see if it helps.
Did they
That's right.
look at in asthma at all? I mean, it's curious.
Which drug?
But I think it
Anti-IL-17.
It has been, but they did one initial study and it was not promising. So, yeah. That's all I got.
I think they're like a couple thousand, but it's there's a lot of built-in costs. So it's like something dollars.
Yeah.
It's one of the problems with some of the other
It's a GLP-2 agonist.
It's crazy to me. That standard drink. I just when I would have there's always one
It's just kind of like automatic.
I think if you look at something on the West Coast, is fully okay with it and believes that it's useful to diagnostic. I mean, it's a great tool, not in terms of diagnosis, but in terms of following.
Sorry about that, I was like, yeah.
Well, in terms of like, yeah, she seems lonely. In terms of like, she seems most.
Got to work on that with the guys. Teal's got to work on that.
Research.